Now it's an honor and a privilege to introduce our next speaker. It's Professor Filip De Somer. He's currently the head of the perfusion department at the University of Ghent here in Belgium. He's a highly respected perfusionist all over the world and is affiliated with several universities in Europe. He has performed important research on goal-directed perfusion management, and he will discuss in this seminar transfusion triggers during CPB. Filip, the floor is yours.
Good evening, and thank you very much for the very kind introduction. I would like to thank, first of all, EACTAIC for the privilege to participate in this seminar. When we are talking about transfusion trigger during cardiopulmonary bypass, it makes sense that we start by looking at what is published in the guidelines. And the most recent European guidelines date from 2019. And what they state is quite simple. As you can see here, we have a situation, a hemoglobin below 6, where it's recommended to transfuse packet red cells under every condition. We have a situation where we have a hematocrit more than 24% or a little bit higher than 8 hemoglobin, where it's not indicated to give transfusion. And then we have this gray zone between 18 and 24% hematocrit, where it's stated that it might be necessary depending on the adequacy of tissue oxygenation. However, if we look to the references on which this is based, it makes sense that maybe this is inconclusive information. So, what was the evidence? Well, there is quite some evidence on hematocrit, not on the absolute value, but on the fact that once you go below a certain level, and during cardiopulmonary bypass, this is probably somewhere between 22 and 24%, there is a steep increase in all kinds of morbidity as well as in mortality. But of course, there are the guidelines and there is the clinical practice of every day. So it's important to see how well are these clinical guidelines followed, and if not, what could be potential reasons why people are not following it. This recent survey actually probably can give us this information. And as you can see from the results, most people would actually say that a hemoglobin of less than 7, remember the guidelines said 6, they would require that transfusion would be beneficial. We see that about a quarter is stating below 8, they would actually transfuse. Together, it would be more than 50%. But very interesting, a large group, about 1/3 of respondents, is saying, you know, we should take in consideration individual triggers. So what could be reasons why people are actually doing this in clinical practice? First of all, it's important to understand, and it was already very well demonstrated by the previous speakers, that hemodilution is an issue. And that means that even if you do not transfuse the patient, it remains an issue. And preparation of the patient before the operation makes a lot of sense. And you can see that in this work from Ranucci, where if you have a patient who starts with a normal pre-surgery hematocrit of more than 40, and because of that, there is a low hemodilution during cardiopulmonary bypass, in this case, always more than 28%, then we do have a low mortality and morbidity. However, if we are in the other way of the spectrum and the patient is coming in the OR with already a low hematocrit, in this case, less than 40, and because of that, he has lower hematocrits during cardiopulmonary bypass, we see that the risk is almost twice as high. So meaning it's important to take the necessary measures during cardiopulmonary bypass, but probably it's as important to prepare the patient as well as possible before. But then the big question is it really hematocrit, or is it actually the oxygen delivery towards the tissue? And Marco Ranucci was the first to point out in 2005 that in his group, where he worked at normothermia, defined as